about what's going on in the TL junction. We're going to want to get a general idea of what the lumbar spine is doing before we jump into this, okay? Because if we have problems in the lumbar spine, we're going to need to clear those up ahead of this, okay? And what I mean by problems is if we have biomechanical dysfunction here, especially that's non-painful, we want to clear this up first before jumping in here. If, however, we have pain here, we're definitely going to want to go here first because the pain here is probably coming from whatever is coming out of here, if that makes sense. So basically, we're going to say, and I would be right behind them, right, to look at this sort of thing. We're going to say, let's drop your right shoulder to your side here. Again, we should have a good view of the curvature of the spine because of the attachment to the skin. Looking for any potential deviations. Maybe looks a touch muscular there. He is actually swinging to his right, which is incorrect. Right? When you side bend through here, the functionally correct movement would actually be to produce latection. So he's a little bound up, but to be honest, it's probably right here around T10 that's happening. Okay, let's go the other way. And you can see that, how he swings back on this side, right? So he's looking a little funky going on to the right side there. Okay, so that's all I really need to do, is just side bending down through the lumbar spine to see how that looks. Doesn't look too bad to me. Go ahead and go back to the right. No major kinks in there. Let's go the other way. Maybe a little tight there, but that's probably muscular. You can see that kind of popping out there. So pretty happy with that as long as he's not having pain with those movements, and we're okay there. Okay, now we need to look at one other thing here in standing. Have to look at least this one thing in standing for the TL junction, and it is standing rotation. Okay, when we're trying to diagnose what level 10, 11, or 12 is problematic in the TL junction, T11 will tend to be most noticeable if the restriction is consistent between standing and sitting. Now, to be honest, I've thought about this for a long time now, and I can't think of mechanically why that's the case, but it does tend to be the case. Okay, so we need to take the hips out of the equation here, so we'll hold the hips in place. We'll ask him to turn to his right as far as he can go. Looks a little tight to me. Try going the other way. That doesn't seem quite as bad, but then again, I'm not straight at him, so try it again. Go to the right. Yeah, go to the left. Yeah, it does look a little tight going to the right, but it's not what I would consider a gross loss of motion in that direction. Okay. Now we could, in this particular position, we could go through and look at T10 and T12 if we wanted to. These are going to be essentially latection motions. I say that so often during classes, it's just ridiculous. So if we're landmarking these, we're going to come off of the 10th ring, just come straight across to the middle. That's going to be about T12, right? So it's the bottom of the 10th rib here. We just come straight across, we're going to be about T12, so right there would be good. We're going to produce a side bending, at least down through that segment, and then rotation. Okay, assessing for our end field, looking for excursion of movement. We're going to go up to T10, just up 2 segments, and that's not feeling so hot. Right? So now we have kind of an idea, right? Not too concerned about T11 yet, just because there's no particular gross loss of motion there. T12 didn't feel too bad. If I'm really interested in T12, I could come back in and do a full extension moment on that. That doesn't feel too bad at all either. Okay, so he's turning out to be kind of a lousy model for this stuff. That's all right. We forgive you. We forgive you. All right, come on over and have a seat just on the end here. Face it that way. All righty, so now, once we're into this position, we're curious, does he have that same amount of rotational loss as what we saw in standing? Right? If it's consistent and it's a significant amount, then we're looking more at T11. So go ahead and turn to your right side. That looks pretty good to me, actually. Right, go to the left just to compare. Yeah, so not too bad. So I'm not terribly concerned about T11. Probably In this scenario, if it was me in clinic, I wouldn't even go and do our passive mobility tests of T11. But I'll show you how to do them here anyway, because you gotta learn somehow, right? So, in this position now, I'm especially interested in that T10 segment. Right? So, we come across, and there's my T12, so I'm gonna move up, there's 10. What I'm gonna do is I'm gonna side bend him down to about the 10th ring, and then I'm gonna rotate him, and that is not going anywhere, right? So let's just compare to the other side. We can see the difference. Good. Yeah. See how much more movement he has there. Okay. I can again, just from the change in standing to sitting, go in and recheck T12. And that feels pretty smooth. So again, if we were having a problem, we'd end up with something like that. Or we're just not able to get that mortise to lock up there and kind of end up here, but he's pretty good shape there, so we're not too concerned. Okay? Now, with the 10th ring, right, we're looking at latection as being an issue. I'm not concerned about rotection because it's not the force that's going to go through this segment during our functional task, right? So I'm not going to get worried about T10's rotection. Could I be concerned about the rib? Yes, I could. The easiest way to assess that is just to lay him in prone and do our anteromedial posterolateral assessment. In this position, I can come in, so there's the 10th rib, there's the 11th rib. Now, how do I know? I can always follow it around until I find the pointed edge of it, right? Making sure that I'm on one of the floating ribs. And I can look at just overall mobility of this rib, right? This rib only attaches to the vertebra, does not have a costotransverse attachment. So this thing, if it's jammed up, will be jammed up in pretty much every direction, right? So all I have to check is kind of this anterior-posterior, almost like calipering motion of the rib, right? So if I drop down back onto that rib there, we're just going back and forth looking for mobility, and I'll drop to the 12th rib. His 12th rib doesn't feel great, actually, on that side. Is that tender there too?
No, I just feel stiff.
Just feels stiff. Be kind of curious, is that?
That's a little tender.
Yeah, so if I drop onto his QL, 12th rib dysfunction, almost guaranteed you will give you QL trigger points. If I drop off the rib, fall into the quadratus lumborum and just dig into it a little bit, it's going to feel a little tender to the touch. It's a good way to say, okay, I need to look at the TL junction as well. If you have somebody come in saying, like, I'm having pain out here, probably the first thing I'd do is just poke them in the QL just to see if it's tender. If it is, then I know I'm going through here. Okay, so we've got two things that we need to essentially treat here. Right? We've got T10 latection, very simple. There's nothing different about manipulating T10 into latection than any of the other segments that we've been showing you up through here. The only potential pitfall that we may have is that it might be harder to get good purchase on T10 because it's, you know, having to get this all the way down to the table and find a good barrier is a little bit harder, sometimes lower in the spine. But should be very doable in our typical supine technique. Now we can do another kind of more consistent PAVM gliding assessment of this in sideline, which would make some sense because I'm going to go ahead and show you guys what it would look like to do the passive glides of T11 and then of 12 as well. Okay, so why don't we have you lay on your left side there for me.